And we can look some more at that when we look at the income statement as far as the dollar amounts involved. On the next slide, we've got our overall eligibles and the distribution between the different funding sources and the change that we've seen in terms of folks being eligible as DABs versus TANFs and Healthy Michigans. And you can see the decline between October 24 and October 25, and those are fiscal years, not calendar years, where there were 44,000 eligible DABs last October, and this month we're under 39,000. So that's about a 15% decrease, and you can see the increase in the number of Healthy Michigan folks. Breakdown of our balance sheet items, our assets, liabilities, and our net position. We've got about the same amount of cash and investments, about $49 million. Our receivables went down by a little over $5 million. Our other assets are fairly comparable, as are our capital assets, the change there being depreciation. Similar to the receivables decline, we also saw a decline in our vendor payables. So we got paid and then we passed money through to providers. The amount due to the state, our employee payables, and our long-term debt is fairly consistent as well. Again, the change there between 24 and 25 being the payment of some of the principal. And then our overall net position, you can see that we had about a $570,000 deficit. And that's, again, a little bit, I think, better than what our annual monthly deficit was over the last couple of years. So we see that as an improvement, but still a lot of challenges and a lot of unknowns in terms of potential increases to eligibles because of changes in the criteria for eligibility. And we continue to receive directives about payments for services that don't necessarily carry a thread of funding with them. So we're continuing to advocate to improve.
Is this chart comparing month-end October to month-end September?
Yes.
Okay. Yep. I just want to make sure. So you shifted from year to year to a month comparison.
Yeah, and I'm going to discuss more with the Finance Committee about how they'd like to see financials going forward.
Okay.
But for this particular presentation, it's last month versus this month.
Okay. Fine, everybody.
Mm-hmm. And then because we're only looking at a single month, I presented the statement of financial activity, or the income statement, for lack of a better description, simply as a financial statement. We've got overall Medicaid revenues of about $35 million, our state general fund of about 1.1, county funding of $2 million, and other funding of just under $2 million, for a total of roughly $40 million. Again, on an annualized basis, that puts us at about $480 million. We think it's going to be slightly more than that by the end of the year. And then our overall breakdown of our payouts, our expenses, and you can see that our administrative costs on a percentage basis still remain extremely low, just over $2 million related to $37 million paid out to providers. Our total expenses were $40,564,000, and we showed a deficit funding of about $571,000. Does anybody have any questions or follow-up? That's a single month, yes.
So in the payouts to providers, is that sure I frame my question right. That's just the direct payouts. It's not any settlements since we're starting kind of the new fiscal year.
Correct.
Okay. All right. So I know this time of year we usually have settlements in both directions, which leads to a budget amendment. What's the anticipation of our BA1? Is it January, February?
So I'm going to propose that we look at a budget amendment for the June Cal report, for the June Cal meeting. Because I don't believe that we're going to have enough data to accurately demonstrate a solid budget amendment.
So rather than two in a year, we'll just have one, because typically there's one December, one
Yeah,
June.
about a mid-year adjustment.
Well,
Slightly less than a mid-year.
yeah, I was going to say. So, okay.
And what are you saying the benefit of that is?
Well, probably the biggest benefit is just accuracy, is understanding more about what the future looks like. I believe that we'll have some policy decisions that'll be a little bit clearer in terms of where MDHHS is heading. I know that we're engaging in different types of advocacy avenues, and we'll be able to bear some of the fruit of that. And we do have some ongoing reviews of prior year cost settlements that should have a meaningful effect one way or the other on our bottom line.
Sarah, any questions? Oh, Dennis, go ahead. You're good. All right, go ahead.
I think there was discussion that we would be going, since we're on finance matters, we'll be going, is it an RFP for audit services? Okay. So
Yes, so we extended the audit for this year for BDO, and
Right.
we are in the process of finalizing an RFP for future
Okay.
years.
Well, just one thought that came up just for us to think about is many organizations I've been on boards of have a separate audit committee. Sometimes it's the finance committee functioning as the audit committee. And maybe we ought to think about that, because then that committee could review the proposals and sit in on, typically they have somebody from the board sit in on those types of presentations.
Yes, thank you. An excellent point. I don't have an opinion one way or the other about a separate audit committee. I will tell you that in preparing the RFP, we do have an intent to request 2 board members to be evaluators on that,
Okay.
on that proposal.
Okay, no, and that's fine. I just wanted to bring it up for the board's benefit, and maybe when we talk about it in a week or so, we're going to have our little study session about goals and maybe changes to the bylaws. That might be something we look into of we got a couple different options, so, okay. Thank
Sure,
you.
and yeah, we reviewed the prior RFP from several years ago, and there were 2 board members who served as evaluators.
Great.
But an audit committee would be an
Two
enhancement
different
to that.
things. One,
Yeah.
I agree, we need to talk about audit committee,
Yeah.
but we need 2 board members, and I think there was
Yep.
some, yeah. So we don't lose steam on the
Right.
RFP. So,
Right. And when would you anticipate that going out? Because we got to give them a little bit of time.
I think it's January.
January?
That we're
Good.
targeting, yeah.
Okay, great. Thank you very much.
I don't know.
Mr. Hooper has his hand up.
Good afternoon, first of all. It is good to be back. I wanted to speak to the issue of having an audit committee. We established the finance committee, and we have only so many members to use for another standing committee. If we chose that to include something like that, and we discussed it next week, I certainly will include it in the presentation. However, my recommendation would be to make it a subset of individuals who are already on the finance committee. So, just an observation.
Okay, thank you. Good.
any other questions for Robert on the October financials? Hearing none. We'll kind of have a similar presentation next week. Okay. All right.
Thank you.
Thanks, Robert. Item B, contractual obligations over 100. We have contract Chris. There you are. He seems sprinting up to the microphone.
Good evening, everyone. I'm Chris McBettridge. I'm the Director of Technology and HIPAA Security Officer for OCHN. We are seeking a one-year contract amendment for Illumint LLC for our HIPAA and cybersecurity audits. We have used Illumint since July of 2021 and would like to do so again before we go out to RFP for the services next year.
What's the timeline on the RFP?
I do not have that in front of me. I believe that we've already expired and want to do an additional round of security testing. So we reached out to Illumint for a one-year extension of their quote. So I'm going to say that that's going to go probably, it should be July 2024 to July 2025, if my math is right based on when we initially awarded the contract.
Okay. And then the next RFP process would start?
It would start in 2025 to continue the services at that point for the years going forward.
For how many years? 3?
Ideally, I would like to do a 3-year contract with probably 2 one-year extensions for the next company. It just seems to work out better that way.
Sure. Okay.
The RFP's process is pretty extensive, so.
Right, and getting more extensive every year with cyber.
Exactly right. And, we've worked with Illumint. They've done a really nice job. I feel like we've increased our security posture over the past 3 years. And actually, with this round of testing, I've asked that we go a little bit deeper than that and actually go through a what-if scenario, if you will, so that we can actually go through and test our cybersecurity incident response plan. So stuff hits the fan, what are we going to do?
Okay.
And they can help us simulate that.
Okay, good. Any questions from Finance Committee members?
So what are you anticipating the increase may be? Are you looking at that in relation to the cost? If you're asking for an extension of the contract, right?
Right.
And because it is about to expire, so you're going to evaluate going to a 3-year. What are you looking at in relation to the cost difference or the increase? Is it a 10%, 15, or do you think you'll be able to keep it at the level that it is?
I'm hoping that we can keep it at the level that it is. I can tell you that the $43,000, when we reached out to them, they had an idea that we wanted to go a little deeper with our testing. We may not need to do that in the years going forward, at least not the first initial year. What they did for us year one was they came in and they did external penetration, they did internal look at our network, as well as looking at our HIPAA policies to make sure that everything looked like it was good. We will probably repeat that again after this contract expires with the next contract. So going forward, I would probably say that it's going to stay pretty close to the same range. This may have been a little bit more just because of the deep dive that we want to take at the end, at least for my satisfaction, knowing that the past 3 years, the steps that we've taken have put us in a good place to weather a storm. So I really believe that we should stay in that $45,000 range going forward.
I know this is not in your area. I was excited about reading the report. Okay, that's number one. But with the shooting of the United Healthcare person, CEO, and maybe we need to look at that in relation to overall security. We have a CEO here, okay? And when I look at the changes that we've had to make and some of the concerns that people had, it says there's an increased vulnerability. And again, I know this is cyber, so probably look at security to see, and I'm hoping, and maybe I don't know to address you as our chair, about making sure that we have put the precautions in place. Most places now, as you probably over the news, are saying, hey, we're taking people's pictures off trying to alleviate or eliminate as much information as possible regarding persons at that CEO level, okay? And so, I, you know, I don't know how this ties in or not, but it's a good conversation.
It's a great
in relation
conversation.
to what you're doing for this, but I also think that we need to look at that, consider that, or as our security person to evaluate that.
Yeah, it's definitely something that I would love to talk with Mark Duguid about as far as the physical security for the building and stuff like that. I'd be more than happy to lend my expertise in that area.
Okay.
But you're right, it's a good conversation to have for sure. There's a lot of bad guys out there.
Thank you. Thank you.
Okay. Any other questions from Finance Committee? Or from other board members?
Mr. Huber has his hand up.
Hi, I just wanted to address the security concerns, specifically as it relates to information on websites or, in particular, public-facing media. The information regarding the officers of our organization is public information, and it is otherwise subject to FOIA, and is otherwise required to be displayed. The name of our CEO is something that the state actually publishes as well, and they request information regarding our officers. So we really wouldn't be accomplishing much if we did try to move toward removing that information. And we do want, in fact, to have our organization and our leadership to be recognizable. Ideally, we would like to have a good relationship with the community, and that is where we need to work together to increase the goodwill for the organization. That's the greatest safety that we can.
Thanks, Bernard.
You guys got me going today. And I guess I want to make sure that we are ahead of the game, okay? And I don't know what we have to do with the county, state, or whatever, but we want to make sure that we're ahead of the game. And when I look at my package today, and, I see out of the, 334 persons, and I see a lot of no's more than yeses, it sort of raises my level of concern in relation to people's reaction. And so it may be that we can do nothing but talk about it, but I think that we should make ourselves aware of that, and whether it's securing our CEO in the building or outside of the building or what, but we need to make sure that we are taking necessary precautions.
Nasser Doss, CIO. I just want to add that part of the HSAG review is physical security, and I remember I was in the audit last year, and we passed that. Does that mean we're doing everything 100%? There is always an area for improvement or opportunity for improvement, but just wanted to let you know.
All right. Thank you.
Okay, I didn't read this as physical security. You opened a can of worms. It's open. What exactly is in? I read this as comprehensive IT, cyber. I see there's social engineering. So it's a question in those areas. We're getting into physical.
This really doesn't cover any of that physical aspect.
Let's compartmentalize these from a risk management standpoint. I don't want to say we're going to evaluate physical if we're not, given everything you said. So, and keep in mind that some of those companies that are taking down their stuff are for-profit or essentially governmental. So let's keep this in a box. Right?
So what's the question one more time?
Well, I think you two just said two different things, so I'm concerned. I heard this is IT,
yes.
Cyber. You said we're including physical.
Let me explain it.
Okay.
So servers, for example, and firewalls, all of that is logged somewhere, right? So the badges that you need to access different doors and different floors at certain point, at certain time of the business hours. All of that, the cameras, all of that physical security, but it also falls under IT because it has an IT component, whether you are locking a server or you have the server that handles the cameras, for example, logged somewhere.
Right.
Does
In my
that make
world,
sense?
that's all under IT.
Yeah.
What Pastor Jones is talking about is guards and metal detectors and things that I don't really want to get into in this discussion. That opens up a whole different set of issues.
Well,
And not what's in this proposal. Right, yeah. That's a different conversation.
Agreed, and it's not in this contract.
Yeah,
Yeah.
and I understand that it's a different area. The purpose for my raising that is the purpose of awareness, for that. I've heard an ounce of prevention is worth a pound of cure. And so just want to be sure we're on it. And I know when in your presentation it was IT. I understand that. And I look at other parts of our report and what's going on, and I say there are flags, okay? And woe be it from us if we do not recognize those flags. So that's the thing. So it may be it's a physical, and we talk to our physical security people and all of that, that's fine, but let's just make sure that we are ahead of the game instead of behind the game. Thank you.
All right, we'll leave that with Dana and Trish. I mean, now we've got it in an open meeting. We got to address it next week in some form or fashion. All right, can I get a motion for this one before we go even
So moved.
further off track?
Second.
Thank you.
Thank you.
Any additional questions? If not,
Thank
Sheila,
you,
can we
my
do a
friend.
roll call?
Thank you.
Mm-hmm. Dr. Guadalupe?
Yes.
Pastor Jones?
Yes.
Mr. Young?
Yes,
Yeah,
thank you. All right, back to you.
Thank you, Mr. Young. Next, member experience report, Wendy Schiller.
Good evening. Marquita Massey, the Director of Quality and Regulatory Compliance. I'm here this evening along with my fellow teammates, Wendy Schiller, the manager of our team, and Sean Taylor, Quality Analyst, and we are going to give you an update on our annual member experience report. Another name for this would be Satisfaction Outcomes of Persons Served. So just a little bit of background about how the process is done and what this is about. What this is a random selection of persons served that have been in service at least 12 months, and it is anonymous, and I believe this was done in the spring of this year, so it's over like a month or two time window. A couple of years ago, based on the recommendation of this board, we moved to using an NCQA certified vendor to administer this survey. Prior to that, we used a person served run organization to administer this survey called MSET. So we've had this vendor in place under contract a couple of years. What this survey looks at is 4 different domains of service. It looks at services, accessibility, acceptability, and access. The area, an important point to point out is that our scores in the area domain of services are above 80%. And that puts us on par with what we see with the health plans in Michigan. We do have some areas where there is room for improvement. So we do have some thoughts on interventions that we took last year in response to the survey results, and then also some interventions that we are going to implement for this year. I mentioned the survey is an anonymous survey, so we don't get any, we get very limited information about the individuals that actually complete the survey. But one action that we can take is to begin to add some more questions to our needs assessment survey that'll give us more information to help us to delve into what people are really feeling. Like, for example, in the area of availability, we will probably be exploring, looking at querying persons about maybe self-help groups that are of interest to individuals. And we would also look at some questions that would help us to delve more into the domain of access. So that's something that would be included in our needs assessment for FY25, with the hopes of maybe giving us a little more information about what people are really feeling out in the network that are receiving services. So I want to turn it over to Wendy and Sean to talk a little bit more about the actual survey results.
Thank you, Marquita. So this year, we had about 384 respondents to the survey. We had mailed out 2,750 surveys, and that is about a 14% response rate. So that is kind of, like Marquita mentioned, on par. We kind of like to look at Medicaid managed care plans and see how we can compare with those agencies. They were at a 13.3% response rate. We did have a higher response rate for children than adults in the survey. I think Marquita already covered talking about the domains that we look at. For the demographics, you see a slide up there that just shows, as usual, we have just slightly higher male respondents than females. And we had about, I think, was it 51% white? Let me find my notes. And 28% respondents were Black or African American. So this is representative of the race that we find in Oakland County. So we like to see that the responses that we get would be representative of the people that we serve. So Sean has really been looking at the data and doing the analysis this year and working on interventions with the clinical team. So I'm going to turn it over to Sean.
All right. Thank you, Wendy. So I'll be covering more of the data side, like Wendy said. So for this slide, there's 4 composite measures that were developed for the ECHO survey by the Consumers Assessment of Healthcare Providers and Systems Program, or otherwise known as CHAPS. These 4 composite measures cover getting needed care, getting care quickly, rating of overall care, and how well clinicians communicated. For getting needed care, OCHN had a rate of 70%. Getting care quickly, we had a rate of 64%. Rating of overall care was 80%, and how well clinicians communicated was 87%. OCHN had a higher rate in each measure compared to the Midwestern region, which is comprised of Illinois, Indiana, Kansas, Michigan, Minnesota, Missouri, Nebraska, North Dakota, Ohio, South Dakota, and Wisconsin. Furthermore, we scored higher on each measure compared to the national rate. Next slide, please. These next few slides will go over some categories that NCQA has determined to be important for assessing member experience and satisfaction. The first category that I will be going over is related to services. We met the goal for measure 13, which is how often did the people you went to for counseling or treatment show respect for what you had to say. The goal for this measure was 90%, and we had a rate of 90.7% for fiscal year 24. We did not meet the goals for any of the other measures, but we were close for several of them. Something to note regarding the goals on these next 4 slides: if we met a goal for 2 consecutive years in a row, we increased it, making it more difficult to hit each year. This could help explain why we did not hit the goals for some of the measures. Furthermore, I will discuss the barriers that were identified for why we did not meet these goals in fiscal year 24 and the interventions that are being used to address them. Next slide, please. This slide covers the accessibility category. We exceeded the goal for question 39, which is how much of a problem, if any, were delays in counseling or treatment while you waited for approval. We had a rate of 86.98% for the measure in fiscal year 24, which is higher than our stated goal of 85%. We did not meet the goals for any of the other measures related to accessibility. Next slide. This slide goes over measures related to availability in the network. Sadly, we did not meet the goals for any of these measures, but the measure with the highest rate was measure 22, which is were you given as much information as you wanted about what you could do to manage your condition. We had a rate of 76.65% in fiscal year 24 for this measure. Like I said, barriers and interventions will be discussed later. Next slide. Something to note before I start talking about the contents of this slide, an error was identified on the slide and was corrected, so it might look slightly different compared to what was sent to the board earlier in the week. This slide goes over measures associated with acceptability. The only measure that we met the stated goal for this year was measure 29, which is how much were you helped by the counseling or treatment you got. We had a rate of 83.9% for fiscal year 24, which surpassed our goal of 75%. Next slide, please. The next few slides will go over the barriers that were identified for why some of the measures did not meet the goal set by OCHN and the interventions associated with the barriers. The QM department worked with the clinical department to help identify barriers and create interventions for them. Furthermore, the slides will have rates for fiscal year 23 and fiscal year 24 to show a comparison between the years. A chi-square test of independence, along with a Yates correction when necessary, was performed comparing fiscal year 23 rates to fiscal year 24 rates to ensure that none of the drops in scores were statistically significant. Each chi-square test showed a non-significant p-value, or showed non-significant or a p-value greater than 0.05, indicating that none of the changes were statistically significant. Now onto the barriers. The most common barrier for these measures were staff shortages/turnovers. Some interventions developed to hopefully address these barriers are to update the guidelines for services that can be provided via telehealth and encouraging CPAs to focus on staff development through trainings aimed at trauma, stress, and practitioner burnout. Next slide, please. The most common barrier for these measures were lack of communication with treatment teams, physical location of clinic, costs of updating clinics, and lack of opportunities to incorporate family. Some interventions developed to hopefully address these barriers are to audit the care coordination protocol, to look for areas for improvement, continuing to monitor clinical concerns and root cause analysis for instances when care coordination between internal teams is not met, and expanding who is considered family per the audit tool. Next slide, please. I want to point out to the board that there was a last-minute change to this slide, so measure 26 will look different on the printed version compared to what is shown on the screen. Now I'll jump into the barriers. The most common barriers for these measures were lack of consistency in provider network, giving information about supports and self-help services, lack of training on evidence-based practices and interventions, lack of training on implicit bias, and no DEI policy. Some interventions, okay, actually next slide, sorry. Barriers identified for measure 28 were high caseloads, less time to spend with individuals, and recent graduates with developing skill sets. Interventions identified to address these barriers are reviewing the hiring practices that could be impacting providers, providers increasing the offering of group sessions, increased supervision, ensuring clinical supervisors are adequately trained, and know how to supervise staff. Thank you.
If anyone has any questions, we'd like to take them at this time. Oh, Marquita.
You want to talk a little bit about how the goals are set that we had for each of those areas. I believe those were goals that we identified that we wanted to reach.
Yes. Yeah, and each year we evaluate those goals, and some of these have been met in the past, so we raise the bar a little bit each time, so you can see that a lot of these we haven't met the goal. It says no, but that may have been because we did increase the goal. So I know particularly last year we ended up increasing many of the goals, so that does play into it as well. Are there other questions? Yes.
Dr. Hahn.
Well, this is very sobering. Apparently, with 80%, and you said our numbers are better than comparable organizations that provide these services. So this kind of, shows the overall picture of mental health care in the state, I suppose, or at least in this region. And we keep on increasing the number of goals. Wouldn't it be better to keep focus on some of the more important things that may raise our performance a little bit? Especially because there is a shortage of staffing and training. I think we should focus more on those, how we are evaluating these services rather than completing a report. Of course, that is important and necessary.
Thank you, Dr. Hans. That's a good point. We, as an NCQA accredited organization, we do have to administer this survey. But it's important to point out that we do have other sources that we can obtain feedback from individuals about services. So the point that I mentioned about our needs assessment, we need to dig a little bit deeper to really find out what people are feeling out in the network and maybe ask them more questions in our survey that we issue to them. I know last year, Francis reported that we really got a really good, strong representation of respondents from people served. So we want to be able to use that data that's coming from them to find out what they're really feeling, because this survey that we send out it's required, it's standardized, but it really doesn't give the person an opportunity to provide any more feedback to us.
Yes, yeah, I think this is becoming more and more important now. Last week was my major professional conference, and now even the physicians, the radiologists, when they dictate a report, which is basically for the benefit of the clinician to come up with a better plan of care or diagnosis, etc. But because the EHR are accessible to patients or people, now we are required to give a summary in a language that is at the 10th grade level, reading level. So how the surveys are worded even are important, because the person completing the survey may not even understand the question. So I think those things should be emphasized. Thank you.
I guess that
Ms. Newman.
I'm sorry.
On item 15, where it talked about the physical location of the clinic, cost of updating clinics, and space not trauma-informed. what is it, what is meant by the space is not trauma-informed? What does that include?
That would be the individual's perception of what's trauma-informed, because the survey itself doesn't provide any additional clarity in regard to that question. It doesn't provide any definitions.
Okay, and then on 26, the diversity question, the intervention was done, right?
Yeah, these are the interventions for the following year. So I'm sure there's some providers that have them, but ones that don't, we will identify.
But if, I know it's difficult with the shortage of staff, but getting a diverse staff, how are we supporting our providers and getting more diversity within their staff?
I'll just add that we did fairly well on this question. Looks like we had like almost 89% favorable. I know that there is activity happening out in the network in regard to that. I think, Wendy, you have a little more you wanted to share in that regard?
Well, I was just going to mention that that question in itself is asking the person if the culture plays into their treatment, so it's not really a judgment of like anything we have or haven't provided to them or any services. That's just a judgment on their own needs, basically, if that makes sense. So I don't know that we've targeted actions to take based on that. It's just to give us an idea how many people have certain needs. So we're focusing on making sure programs have DEI programs and are hiring diverse staff and that sort of response.
Okay, thank you.
I do have one question related to number 28. What was the numeric average number for 28 from that 0 to 10? Because that would kind of give me where we're at. Because when you say 0 to 10, was it a 5? Was it a 7?
I don't know if we looked at an average. How we kind of looked at is responses that were like a 7 and above were considered preferred responses, and anything below was considered not preferred. Yeah.
Yeah, just the way we score it is.
Yeah, we don't really look at it as an average for it, but I'm sure that's something we could get for the board.
So what number were you shooting for? What would have been a yes?
Well, like 7 and above would be 7 to 10 is our preferred, like that would be a preferred answer. Ideally,
between
10.
70 and 100 is what you were looking for then? Okay.
Yeah.
All right. Thank you. And Pastor.
Thank you very much. First, let me thank you very, very much for this report. Wendy and I remember before I spoke about the trustworthy issue, and you sort of spoke to that. Here, I'd like to ask, is there an area that you did not check, that you say, wow, it'd be great for us to know, great for us to look at that, and that's more, I think, outside of the box and what have you. Is there something else that you, after looking at the services that you're getting and what they're tracking, and maybe you've given them the tracking, but is there some other area? That's number one. And I raised that because, you know, this year, going out of this year, 2024, we had so many people that were talking about transportation, availability, services, dollars, you know, not being paid enough, and blah, blah, blah. All of that comes back to saying, okay, what is your satisfaction? And the fact that out of I think you said 2,700 people, and we get 375, the 14%, then the question is, how do I move the needle, right? Or how do I get more responses? Am I asking the right questions? Or people said, they didn't ask me what I really want to say. But they come here and they say what they really think. So I'm not sure if there's something else in the questions we ask, looking at the survey, or as you all sit and say, here's something we'd like to know. So, and I don't know how to ask the question except to say, I look at that, see the results, and good, for you, but then you say, what am I missing? And especially when in person we hear the people, but it doesn't reflect in this.
And that kind of is what Marquita was talking about too. We can kind of add some things to our needs assessment survey that we have to offer that might give us more detail, because we can see that somebody may not be happy with a certain area, but this survey doesn't really allow for open-ended explanations of what would that be. Would it be transportation or something else?
And
so,
to back Wendy up, those, Pastor Jones,
Yes.
those kinds of Sheila, those kinds of questions will be addressed in our needs assessment survey that's coming out in January and February.
Okay, all right, well, then that'd be good, then maybe we can compare that to see.
Yeah, and we get a higher response rate for those surveys. I think we're up around 900.
Because that also goes back to Robert, as we talk about the groups that are providers.
Right.
How effective are they, in relation to what they're doing and what we're paying them, whatever. So I think there's just a plethora.
Yeah. I think what you're looking for, though, will be addressed in the needs assessment survey.
Okay, thank you. I will save my question to that. Thank you. Okay.
Mr. Cowan?
Yeah. Wendy, what, or Marquita, or both, so out of all the responses that you got, number one, did anything surprise you? And number two, what's the plan to use this study to try and improve? What things do you see that you could do? I mean, this just doesn't sit on a shelf. I assume somebody's going to come up with some recommendations that can be improvements. Because some of the items almost seem to be like check the box. Like, were you informed of self-help groups? Well, there may be, for whatever the situation was, maybe there aren't any really good self-help groups, but those seem to be check-the-box items. And others, I think, when I was reading through this, I was saying, well, what are people's expectations? There's some subjective element in this. Because if people have high expectations, like, you're going to solve all my problems, well, that's not reasonable, but that's okay. We try to meet even unreasonable expectations. But again, what surprised you, and then what do you do with these results?
I mean, I think most of what we saw the same thing last year. So there weren't really any surprises. We have a lot of the same interventions that we're continuing, things we put in place. Some things worked, some things didn't work so well. So we have to really take a look at what was effective, what was not. We work closely with the clinical team. Sean's been meeting with them. So a lot of the interventions he was talking about really were ideas that they've come up with that they're going to implement, writing things into protocols to make them more clear for staff, doing more audits, adding elements to the audits of what we're looking at. We required this year that all the providers have IPOS Golden Thread trainings to really get down to the basics for the staff, a lot of the new staff that are coming in. So there are a lot of things that we've done, and we kind of have seen the same things again repeated in fiscal year 24. So I don't know if you want to add to that.
I'll just add that I know that access has been an area that we've been giving a lot of focus to. And our scores here show that we need a little bit of improvement. But on the other hand, the services scores, the outcomes in that domain were fairly positive. But I do think that we'll have we'll get more rich information from the needs assessment. We really need to find out For the, like, for example, the question, did you get the supports and services you needed on the phone? Well, we don't know from the survey where they tried to call. Did they try to call their doctor? Did they try to call their case manager? Did they call our customer service line? We don't know that. So we really have to try to dig a little deeper to find out what people are really feeling.
Yeah. And just closing on my part, despite all the responses that we got, and maybe on some of them fell short, and a little bit short on some of the goals. The most important one to me is how much were you helped by the counseling or treatment you got, and we scored almost 84%, which is above the goal, but I think also pretty high for any organization that's involved in the type of services we provide. So I thought that was almost an affirmation that maybe I didn't get there the way I wanted or with the ease of how it should have went, but at the end of the day, 84% of the respondents said they were helped. So that's important, and I take that as a positive for the organization. So thank you for your efforts and for sharing this information.
I do have one additional question. When you look at the industry, I know a lot of the baby boomers in terms of clinical supervision have retired. And I know you cited that supervision is probably something that could be increased to help because you've got a lot of people who are now in supervisory roles that may not have had all of the training because of the nutrition of folks leaving the field. On average, if you look across your provider network, what's the tenure of most of those that are now providing clinical supervision?
That is a good question. We don't have that data readily available. That's something we'd have to get from our core provider network, but that's a very good point because that is the background that's really training the clinicians that are coming up.
Right, and I think some of the problems I have seen is that the supervisors are not properly trained in order to train others. And we know that people leave supervisors, they don't leave jobs. Because if their needs are not met, they're not staying. And that's why there's such staff turnover at this point. So I think the industry needs to look at what we can do to get people properly trained so that they can assist others. But thank you.
Thank you. Are there any other questions that we can answer?
Oh, since you opened up. Yes. So kind of, Marquita, you hit on my key point, especially as I was listening to Pastor Jones. So, and this is a tough one, there may not be an answer. Do we know who and what they're evaluating? Are they evaluating the person giving the counseling to them? Are they evaluating how that occurred to the MORC coordinator or the MORC assistant? I mean, we're owning a problem and living in this world. I think, I'm pretty sure I got this survey and struggled with who am I evaluating? You know, and to Dennis's point, is the neuropsych appointment fast enough? Never fast enough. So in some ways, we're chasing the unicorn because, you know, when a problem starts, you want that counseling treatment tomorrow. And if all goes well, it's going to be 6 weeks out, right? And a lot can happen in that 6 weeks. And then the service might be wonderful. So this is so complicated, and this is the third year I'm kind of wrestling with this and watching it. And I feel it's a Polaroid of a speeding train. So, I mean, if you want to elaborate on that, but I just, like I said, when I filled it out, I'm like, which point in time, because I could go from wonderful to terrible to wonderful again. So.
Yes, you're right. It's a point-in-time survey. It is dependent upon where a person is at the time that they actually complete the survey. The survey, although it's standardized as an NCQA-approved survey, it is not, I don't believe it gives specifics on who you are evaluating. Do you recall, Wendy? No. Yeah, so it doesn't really say.
Whoever they interpret.
Yeah,
Right.
but that's where when the board's giving you direction, it's like, fix it. But the it could be, like I said, it could be the support coordinators, there are more support assistants, Yvette and I have talked about this, right?
Yeah.
Supervisors are flying through Easter Seals Mork, you know, kind of moving up, moving out. Coming out of the pandemic, so many more people need psychology that the psychologists are overrun. So I'm saying this because I don't want us to set ourselves up for we're beating ourselves up. And to Dr. Hahn's point, there might be some core issues that we work on, but a point in time, and then the other thing, you know, some of you should get these and you're just too busy dealing with life to go, what's this survey going to get me?
Right.
So
I really think our best bet is going to be to delve down deeper into our needs assessment. I know that that's going to be coming to the board for input on what kind of information you'd like us to gather. So if you could keep this presentation in mind when you get that opportunity, that will be helpful. We're going to be thinking about it internally on what steps we need to take in terms of adding more questions that would delve down deeper into how folks are feeling. So, and we're also going to be talking to our providers to get their thoughts on what they think about these survey outcomes and questions that they would recommend that we maybe add to our needs assessment.
And I, you know, and I agree. I'm going to wait for the needs assessment, but I think out of this is, what do I want to say? Tell me something I don't know that I really need to know, okay? As you're looking at that and saying, does this information give me that? That's why I asked the question, what do you think, okay? If, does it really answer what you wanted to answer? Because there is a gap, and we had said, okay, how do I do it so that I can really use the information that we're doing? Okay, that's the thing. And so I'm looking at not only this, but what is the reality when people come in here and say, here's how I feel about services or what I'm getting or what have you, and then I look at a report like this and I'm saying, well, do I listen to them or do I look at this? So it may be good to look at that, and as you talk to the surveyors or whatever, say, hey, help me with this. Let me think out of the box to see what can I get that's going to help. But maybe, as Sheila says, once we get the needs assessment, we can try to tie some of this together and help us to understand the questions we need to survey.
Yes.
But but Wendy, thank you for what you do, and I remember when we talked about the trustworthy and all of that, and you guys did a good job of addressing that for me, so thank you.
Okay, thank you.
Can I ask just a quick question?
Mm-hmm.
Yeah. So I'm just wondering, when you delve into the data, are you able to look at the difference between the children and adults? Because it looked like there was a lot more families than adults that responded, and so I'm just wondering, some of these questions, like if you look at number 19, did anyone ask to talk to you about whether to include family? A child's probably going to have the family there, so they might answer differently based on that question. So are you able to see the parents answer differently than adults?
Well, some of the questions are adult and children only. So that one with the denominator, I would assume it's probably adults only based off the denominator. But we could look at some measures that are adult and children only. If there's enough respondents in both categories to really figure out the difference there.
Okay. And then I presume because it's a standardized questionnaire, I mean, there's nothing we could change or you could change in the questions?
Yes, we could do that since we do have a vendor doing this on our behalf. So right now, the way the contract is set up, this is how they're doing it. So when we, renew a contract, we could make modifications. We could add questions. We do have that flexibility. I mean, this is how the survey was developed for NCQA, but you can add some questions just for our own information. We could do that.
Okay, thank you.
All right, well, thank you very much. Next, we will have the funding year 24 annual plan outcomes by Francis Carley.
Hello, good evening. Frances Carley, Director of Strategic Initiatives.
Good evening.
So I'm here tonight to provide an overview of the successes and accomplishments of OCHN over the past fiscal year, so through FY24. As a reminder, we were in FY24, we were in the second year of our 3-year strategic plan, focusing on staffing and retention, quality system of care, administration and service delivery, integrated healthcare, and partnerships, advocacy, and outreach. So there were 41 total objectives within the designated goals in 24. Next slide. So the total number of unduplicated persons served was approaching 30,000 individuals this year, and that is across the full service array. The breakdown of the numbers you can see in the chart. Next slide. So as a reminder, the 2 goals under the staffing and retention strategic priority, the 2 goals that we are working towards included cultivating a positive work environment and developing a career pathway for the behavioral health system. Next slide. And to that end, we're happy to report that OCHN was recertified as a great place to work. As part of the survey, the teams have been meeting and going over the results, and implementation has begun on working on those recommendations. OCHN also conducted an engagement survey of direct care workers and launched the direct service provider training module. And so that was new to OCHN this year. We brought it in from another provider and successfully trained over 6,700 individuals through that module. So that was launched and got off the ground relatively quickly. Additionally, the HR team exceeded their target of going to 4 career fairs. They attended 5 to ramp up OCHN's presence in the community and work with the local universities and colleges to bring to help build awareness of the career paths that OCHN and the public health system provide. Additionally, OCHN had 8 interns or co-ops hired this year, and through the apprenticeship program, that included several different focuses and departments, including clinical and various administrative opportunities as well. Next slide. So the key goals under the administration and service delivery priority are to comply with the administrative PIHP and CMHSP redesign function and structure requirements, to use technology to improve provider network monitoring, and to implement budget management strategies. So in FY24, OCHN remain committed to working with the state and partners on implementing conflict-free access to services for people receiving services and ensuring that they are able to have choice in their services. The state is still working on those final guidelines, so there is nothing. We've been working with them with their to the point that they've got to at this stage so far, and continue to be committed to that internally. Additionally, we have been working on implementing standardized rates and implemented new rates for 3 of the service models and also transportation, and continue to work on the other service models through FY25. In terms of IT improvements and budget and finance, the IT team successfully linked the financial system and reporting to Odin, and that was a pretty significant lift, and it is now in place. Additionally, the IT team has been working on implementing or successfully implemented several new software components and platforms to help OCHN manage population health, the contracts, credentialing, and also contact center software. So additionally, with the, in terms of bringing in additional revenue, OCHN brought in over $10 million in new grants, and this is in addition to kind of those state grants, which most of them are multi-year and continuations of current funding. So regardless of that pot of funding, we brought in over $10 million in new funding. Next slide. So for the integrated healthcare goals, the first goal is to improve the healthcare integration outcomes and then also evaluate and expand crisis services. So the first component of this, we have 2 slides showing these highlights. So there were 13 objectives overall under this area, and we had several key highlights and new initiatives, and also success with some of the ongoing initiatives that were relatively new. So for the behavioral health homes, well, the various health homes, we have the behavioral health homes, SUD health homes, and opioid health homes. And the clinical teams and SUD team has, they've been working on continuing to enroll people and make sure that everyone who is able and eligible to access the health homes are able to. And to that end, the behavioral health homes increased to 895 individuals in FY24. The SUD health homes had 89 people enrolled, and the opioid health homes had 251. In terms of a new initiative, which we presented and talked about recently, but it's we had a kind of bigger launch earlier on December 3rd, earlier this month, for the Integrated Healthcare Walk-In Center, which is a collaboration between Oakland County Public Health Division, OCHN, and Honor Community Health. So that is up and running. It is at Pontiac General Hospital, and OCHN has hired a dedicated staff member for the behavioral health coordination. So the access team and crisis team, they've been really working really hard on making sure that the staffing coverage is there and that the program, the protocols, procedures, and then working with the honor team, that is all going smoothly. Additionally, the SUD team has been working on Project Assert to bring in letters of or agreements to create agreements with local emergency departments in order to implement Project Assert at the EDs. And so currently there is a review underway going back and forth with the language for the MOUs. And so that the SED team is hoping to build these partnerships and get everything off the ground in FY25. The team is also exploring the RFP process to expand the capacity for adolescent treatment. So that is still a significant priority. The team, as mentioned previously, the IT team has implemented a number of new software and platforms for to help the efficiency of the managed care organization and services. And to that effect, the clinical team is actively monitoring the public health data that we receive and social determinants of health in order to improve care and coordination for some of the higher needs individuals in the network, and monitoring the data going forward. So in addition to the team, the team also is monitoring the post-stabilization services for following an acute care stay. They worked with IT to build out a dashboard so that this information can be tracked and monitored in order to ensure that this service connection and care coordination is happening within 30 days of a crisis episode. Next slide. Right, and so then also part of the integrated healthcare priority, we have several justice initiatives that have really gotten off the ground this year and have had some great success. The team has been working on expanding coordination with the courts and was able to partner with the 43rd District Court for treatment for fall, launching in fall 2024. The team now has 5 liaisons embedded in 4 courts, and throughout the entire year had contacts with over 3,200 contacts with individuals through the courts that way to connect them to services and provide some diversion or post-incarceration support. And then there's also the new treatment court partnership that launched in the fall. As part of the jail and court coordination and new programming, the team is working with the jails in order to enroll people in assisted outpatient treatment, and successfully enrolled over 500 individuals in FY24. And the program received a grant or 2 grants totaling over $2.4 million this year. So that will help to expand the program in the next couple of years. And in terms of community partnerships, OCHN received a grant for about $1 million from the state for community violence intervention, and as part of that, we were able to launch some community partnerships, including one with Time Out and the Greater Pontiac Community Coalition, in order to reduce gun violence in Pontiac. So that program is getting off the ground, and they've had some great contacts, and professional development is already underway, and the program will be running at least through the remainder of 25. We're also looking for additional funding sources. Also under that grant is the jail transition program, which launched with an organization, Transfer Life. And so they are working with the jail, Oakland County Jail, and have the support of the sheriff to provide these transition services for people who are exiting the jail system. And so that program is also underway. And additionally, the co-responder initiative expanded significantly this year with a grant that the Justice team received for $1 million with the county to several new locations throughout the county. We also received a couple of grants totaling $746,000 for the Community Behavioral Threat Assessment and Management Team. And this is an initiative Dr. Posios and Tricia were getting off the ground for the past year. So having this additional federal funding is really significant and will provide staffing for OCHN and also the Sheriff's Office and Emergency Management to continue developing that threat assessment team and model in Oakland County. For the next priority, the quality system of care priority, we had two goals. The first, to expand access services and also strengthen the children's system of care. So under this, this priority, the access team notably has really been very active, expanding services and still committed to the 24/7 service model. Staffing has been, as everyone knows, a challenge. So they've been really creative to try to find ways to, if they're not reaching people necessarily, in the 24/7 kind of model, how else to reach people. And so looking at different locations, different ways of connecting with people in the community. And so that's been a really great success. And as part of that, they took in the RISE Center, which stands for Recovery, Information, Support, and Education. And in FY24 served over 1,400 individuals, connecting them to resources in the community. As far as the mental health school navigators go, they were able to provide 586 referrals to services to children and their families through the schools and those partnerships. Access also expanded to the a location in Southfield with the Oakland County Public Health Division. And so it's kind of an outstation, outpost location where they're able to connect with people closer, to help mitigate any difficulties with transportation and to meet people where they are in the community. Access also implemented a jail screener, new position, and so working also with the Justice team on this additional point of access and connection to services. In 24, OCHN, the assessment center located in this building, the Troy building, has expanded. We conducted some implemented some renovations on the ground floor for the assessment and diagnostic services, and that includes specialty services and such as autism and FASD. And additionally, the team worked on the Children's System of Care recommendations and the sustainability of the Youth and Family Care Connection. So the team, the clinical practice team, has been working on updating a lot of protocols and conducting audits and really providing that key role as the oversight and managed care organization for the county. And so working on also the clinical pathway for suicide care and the care coordination protocol to help better connect individuals to services and make sure they get those crisis interventions when they're needed. Next slide. And then finally, the strategic priority for partnerships, advocacy, and outreach. The key goal in FY24 was to strengthen the local relationships in Oakland County. To that effect, the communications team and our CEO they've connected throughout the entire year with our state and local legislators, the Oakland and our deputy, we've been working with a local legislative consultant on building out the relationships with the Oakland County partners, and our chief of staff has been leading those efforts and developing some comprehensive outreach materials and connecting with them on different strategies. And as part of that, we also held a breakfast for the legislators in January, and that was also to introduce them to the new legislators to the public behavioral health system and help to connect them to our network and introduce them to the individuals who work here and the work that OCHN provides in the community. OCHN has been working on a SUD prevention campaign, and so the SUD team and communications really have been building out the messaging and created several ads and using multiple media platforms to get the message out in terms of prevention messaging. And we also have been doing the provider trainings, and so over 20 trainings are provided every month. And finally, OCHN successfully transitioned the transportation service line back to OCHN from MORC, transitioning over 2,300 individuals, providing them with their transportation services. So with that, that is basically the overview, the summary. As in past years, we will be developing a more comprehensive written report when the year-end financials are complete. But in the meantime, this was our initial update, and I can provide any additional information and answer any questions that you might have.
Any questions? Mr. Torres?
So the $10 million in new grants, so were those for new initiatives, or is that offsetting other areas of our budget?
Well, depends on the specific grant. In most grants need to be directed to new initiatives and new funding, but there are, if existing staff are playing a role in the new work, then you're able to bill that new work as part of to the grant as part of that. So I would have to go through and kind of piece through, how much of any existing cost is.
Okay.
It's
impressive.
pretty much new,
yeah.
though. Yeah.
So it's a lot of money. So that's great. And then the justice initiatives, we had 5 liaisons embedded in the courts. So are they clinicians or what do they do?
Is anyone from Justice Team able to?
Absolutely. So yes, they are clinical and they're embedded in the treatment courts. So we have 2 in the adult treatment court. We have 1 in the other mental health treatment court. Jordan, Jillian, Megan, not Megan anymore. They're all clinicians though, and they provide that mental health piece with the whole treatment court team.
So they get the diagnosis and then appropriate services then or forward to services.
More of the appropriate services, yes, and how they can connect them with ours.
Okay, like a screener. They can screen though too, right? Like
Yes,
doing
they
screenings
provide
and
extra
things.
screenings.
Excellent. Okay, and then I think it was so the monies with the specialty initiatives. So I think it was. Are we providing the grants, or are we managing the grants, or?
Many of them are direct services. Most of them, we have some contractors for some of them, but it's, and Trish, I don't know if you have additional.
It's mainly us. Frances and her team have been amazing, which is the reason why we got that much of grants. But it could be we're directly employing the co-responders, or we're directly employing the liaisons who are in the courts, or who are providing the AOT case management or monitoring, things like that.
Well, I'm glad to hear, and this is a great way for us to spend our money, with these justice initiatives. So, thank you.
Any other questions from the team?
No, I'd just like to compliment Frances and her team and Trish, on the grants, and especially as it related to the community violence piece. 2 of those programs, Time Out and Chance for Life, and in Pontiac, Time Out, there have not been, since that grant has been implemented and the program, from September to December, no homicides, which says that team is out there working and doing the thing. During the month of November, the Time Out group was able to work to give out 450 coats, and they'll do more this month, which means that probably by the end of December, they would have given out over 600 coats to persons needing. Those coats went to Oakland Intermediate School District, Pontiac School District, Lighthouse, and others, and individual families that, and then they worked to make sure that there were over 150 Thanksgiving baskets that lasted not just Thanksgiving Day, but for 5 days. That is including breakfast for every day and all of that. And I mentioned that because the grant talks about prevention for both of them, and that's what it is. So they are not out there trying to get into the violence, but stop the violence, and be in effect be mediators that keep things from happening. And so when we look at the report from the police department, that from September, October, November, and November, as you know, usually November and December are really high areas for homicide, most drinking and all of that happens, but no homicides. So the grants that you're talking about for the community violence intervention has really proved to be great. And I thank you all, Frances and Trish and your team, for how you're managing through that. Thank you.
Any other questions? I do have a couple questions. Under your integrated healthcare highlights, those numbers, was that where the organization wanted to be?
Well, I think for the clinical team, I can defer to them if there were any kind of specific targets. I know the behavioral health homes, that's increased, I believe, from last year from 500 to almost 900. So I know that there is a concerted effort to keep trying to bring people in, and similarly with the justice team initiatives, some of these were newer programs like the AOT, and so I think it's we do have a target for AOT in FY25 of 700 individuals, and it's currently around 500, but the program also started later in the year, this year, or in 24. But I'll defer to Tricia or anyone from clinical if they'd like to.
I can answer. The programs that started, there weren't any targeted goals at first, but just having a baseline and seeing the numbers increase, that's really the objective, is to make sure that the numbers are increasing so that people are going to the programs. When you talk about the walk-in center, there really wasn't a target, the integrated walk-in center. But what we saw initially was we were seeing more people who have physical health care needs and maybe a lower number of behavioral health. But as we open and get more information out to the community, we know that's going to grow quite a bit. And already they've seen over 100 people for behavioral health care needs, where compared to like 700, 800 people for the physical health care needs. So we're going to see that grow a lot more.
Okay. And the other question I had was related to expanding adolescent services. Are you looking on the behavioral health side, the substance use disorder side, or a combination of both?
Well, on one hand, there's the children's system of care and building that out. That, of course, is connected to the YFCC services, but then also the SUD team is looking to expand SUD treatment for adolescents.
Okay. Are you looking at medication-assisted treatment for adolescents? Because, SAMHSA did change guidelines effective October 1.
I don't know. Is Megan on the line? Is she able to answer that now? Or if not, I can follow up with her.
Okay. Because some states are making those changes based on SAMHSA's recommendation of the guidelines that went into effect on October 1. Any questions? And one last thing under your retention highlights. How did OCHN do overall for calendar year 2024 in terms of staff retention?
I'm wondering if Nicole or Glenda maybe are on the line and can speak to that. The question about staff retention in 24.
I don't see them on the line, but I
Okay.
think we can get that information for you. We looked at that earlier today during our HR committee meeting, so I'll make sure that you have that.
Okay, thank you. We're all set. Thank you very much. Next up, we'll have threat assessment report by Dr. Posio. Come on down.
Good evening, everybody. I'm Dr. Posios, and I'm Chief Medical Officer at OCHN. At a previous board meeting, it was requested that a presentation be given on the causes of violence. While I don't think anyone can completely or succinctly answer that question, I am going to do my best to give some insights into some theories that inform our understanding of targeted violence, which I think is unfortunately a prescient topic given the recent targeted killing of the United Healthcare CEO. Next slide, please. So attacks are rarely impulsive. Attackers don't just snap, or attacks don't happen out of the blue. Attackers think about and plan their attacks in advance, whether it's a few days or months or even years in some cases. School safety experts, law enforcement officials, and the United States Department of Education, Justice, Secret Service, and FBI have cited research indicating that before a person commits an act of violence, warning signs are usually evident. I want to preface tonight's presentation by acknowledging it is a misconception that people with mental illnesses are inherently violent. Indeed, SAMHSA reports only about 3 to 5% of violent acts are attributed to individuals living with a serious mental illness. And moreover, people with serious mental illnesses are often 10 times more likely to be the victims of violence rather than the perpetrators. So with that in mind, it's important to note the pathway to violence focuses on behaviors, not mental health symptoms of an individual. Next slide, please. And before you is a diagram of the pathway to violence. Research specific to targeted violence suggests that individuals often follow a pathway to violence. Individuals move from thinking about using violence to planning and then executing their violent intentions. According to researchers, the pathway to violence includes the following stages: grievance, violent ideation, research and planning, preparation, probing and breaching, and then finally attack. When we talk about attacks being planned out, this is what we mean. When doing threat assessments, we're looking for pathway behaviors, which are different from profiling, which you may have heard of, which involves a focus on demographic factors and shared characteristics. Next slide, please. So in the grievance stage, the first stage of the pathway, someone might feel wronged due to imagined or real experiences, and this feeling may stem from a sense of injustice, victimization, or feeling like an outsider. Behaviors in this stage may include speech, sketches, or writings that are characterized as hostile, sarcastic, or bitter. Next slide, please. The next stage, violent ideation, includes thinking about or considering violence related to a grievance. Behaviors here may include thoughts or fantasies of murder and violence. Next slide, please. The research and planning stage includes thinking about the who, what, when, how to commit a violent act in response to a grievance. Specific targets and tactics are researched, and the attack is more concretely planned at this stage. Next slide, please. Preparing for a violent attack may include identifying and acquiring the means, weapons, and tools to carry out the plan. Practicing with weapons or practicing other tactics occur at this stage. A phenomenon known as leakage may also occur here, though it may occur at other stages along the pathway. Leakage in the context of threat assessment is defined as the communication to a third party of an intent to do harm to a target. So in most cases, shooters will tell people in advance what they're going to do, friends, classmates, peers, and so on, and this often occurs online. Next slide, please. The probing and breaching stage is the 5th stage of the pathway, and this stage includes looking for vulnerabilities that will help the individual carry out the attack. This might include where to commit the act, how to gain entry to commit the attack, or how to escape once the attack has been completed. Final surveillance may be conducted during this stage, and the attackers may also test plans during this stage. Next slide, please. Attack is the final stage in the pathway to violence. And at this point, an individual is implementing the plan and committing the attack. Certain stressors or risk factors may amplify grievances or increase one's willingness to use violence in response to those grievances. It's important to note that some individuals may only move through the first few stages and move up and down stages over time without ever implementing an attack. We're sharing information about the pathway to violence because you may see, hear, or learn about behaviors consistent with some of these stages. Next slide, please. So now that we understand more about the pathway to violence, how can we prevent it? And that's where the Behavioral Threat Assessment and Management, or BTAM for short, comes into play. Next slide, please. So what is BTAM? So school safety experts, law enforcement officials, and the United States Department of Education, Justice, Secret Service, and FBI have cited research indicating that before a person commits an act of violence, warning signs are usually present. Behavioral Threat Assessment and Management, or BTAM, is fact-based. It's a systematic process designed to identify, assess, and manage potentially dangerous or violent situations. The primary goal of BTAM is to evaluate the difference between making a threat and posing a threat to the community. Research and best practice guidelines indicate that a collaborative, multidisciplinary approach to BTAM can identify effective interventions and supports, build a management plan that mitigates a potential threat, and supports the safety of the entire community, while also helping the persons who are the subject of investigation toward a more positive pathway. Next slide, please. BTAM can reduce the likelihood of violence and improve the ability to behavioral health, to serve the behavioral health needs of the individual. In fact, one study found that students receiving a threat assessment were more likely to receive counseling services and parent conferences. BTAM can also promote more fair outcomes. One study showed that schools using threat assessment saw substantial reductions in the racial disparity in long-term suspensions. Another study showed that students receiving special education services also did not receive disproportionately higher rates of school suspensions when threat assessments were conducted. Next slide. So what components are critical in building a successful BTAM program? Next slide, please. Now, I won't go through all of these individually, but before you are 8 stages that were proffered by the National Threat Assessment Center, or NTOC, of the U.S. Secret Service and Department of Homeland Security. And they are considered a best practice threat assessment model based on over 20 years of research, training, and consultation on threat assessment and preventing targeted acts of violence. These steps provide information on the essential foundations to effectively and by using evidence-informed practices, conduct threat assessments, build protocols and procedures that can apply to schools, higher education, community agencies, and workplace environments. As you can see, there are 8 critical steps that form these best practices, and these best practices inform our program here at OCHN. In fact, these 8 steps were included in a chapter on threat assessment in the Oakland County Prosecutor's Office Gun Violence Commission report that OCHN helped to co-author. Following best practices such as these 8 steps will lead to better outcomes and reduce liability from a legal standpoint, so that's important to consider as well. Next slide, please. I now want to spend a little bit of time updating you all on the progress of OCHN's Community BTAM program. Next slide, please. So as we're all aware, Oakland County has experienced a significant increase in the number of threats of mass violence, particularly following the tragedy at Oxford High School. In the aftermath of the Oxford tragedy, OCHN quickly built expertise and capacity to start a CMH-led behavioral threat assessment and management program. Next slide. Over the course of the past 2.5 years, significant progress has been made with respect to building OCHN's BTAM program. OCHN played an integral role in the Oakland County Prosecutor's Gun Violence Commission, as I mentioned previously, including co-authoring the section on threat assessment in the Commission's final report. We have greatly expanded our collaboration with law enforcement, as exemplified by our excellent relationship with the FBI through our connection with the Joint Terrorism Task Force through the task force officer from Oakland County Sheriff's Office. We brought in international experts such as Reed Malloy, Dewey Cornell, and Dave Okada to consult on our program and train staff, including OCHN co-responders and school mental health navigators. We've become trainers ourselves and conducted trainings in collaboration with Oakland schools. Next slide, please. And as Frances Carley mentioned in her presentation, OCHN received a grant from the Department of Homeland Security in a competitive grant process. The grant period is from October of 2024 to September, the end of September 2026. In order to effectively mitigate threats and reduce targeted violence in Oakland County, OCHN, the Oakland County Sheriff's Office, Oakland County Department of Emergency Management and Homeland Security will expand our threat assessment activities through a community behavioral threat assessment and management program comprised of mental health, law enforcement, and community partners. This program will build a continuum of behavioral threat assessment and management that facilitates collaboration and communication among partners while providing access to behavioral health services for individuals who are on the pathway to violence. The threat assessment program will work closely with community and faith-based organizations, behavioral health providers, schools, courts, and other partners to provide training and raise awareness of BTAM. The program design includes 3 project areas: behavioral threat assessment and management, BTAM teams, raising societal awareness, and bystander training. Funding will support 3 full-time staff, community awareness activities, and educational trainings. By fostering collaboration, enhancing awareness, and providing necessary resources for training, prevention, intervention, and treatments, our BTAM program will contribute to a safer community for all residents. Next slide, please. You can learn more about the OCHN BTAM program by visiting our website at oaklandchn.org/BTAM. I just want to remind folks that there is a referral button there. We are not intending to solicit referrals from the community. Rather, that ability for folks to send us referrals is intended for our community partners. But there is additional information about our program at that website. Next slide. Next slide. Happy to answer any questions that you all may have. Thank you very much.
I just want to say thank you. I think it's very important information. I've been able to go through a BTAM training myself. I just think bringing awareness to the community is super important, as well as being able to sit in your presentation at the CMH conference. So I'm happy that you're bringing this information forth to the community, and just think it's very important. So well done.
Thank you.
Thanks.
And looking at this, I appreciate the presentation and the slides and the information. But I look at step 4 of the 8 critical components, and you know, I can't stress enough the threshold for law enforcement intervention, determining that in our works and what we do. After the Oxford shooting, you really saw within the school districts really a huge push of zero tolerance, you know, they were calling it, and that anything that was said remotely involved, that they were bringing in law enforcement. And working in the justice community and juvenile justice community, being an advocate, you can really do a lot of harm to a child if you overreact, especially with children with special needs, autism, those kinds of things. And it was really scary because you were seeing it a lot, and it was just this balance between when to call law enforcement and when not to. And I remember a specific instance, you know, for some context, I'm on a school board as well, so I've been involved with the school community in the state level and the county level. So it really hit home when these shootings happened and seeing all these things. But I think one of the major things that I saw was I remember getting an email about a potential response to an elementary school for a first grader right after Oxford, and the message was zero tolerance, you know. And I had a first grader at the time, and I could imagine that being my kid, right, saying the wrong thing, doing the wrong thing. So I think it is a balance that when we pursue these and we go through our works, that we really pay attention to that step 4, determining the threshold for law enforcement, because you know, one, you know, going too far, the damage that you can really do to a child, because once you introduce a child to law enforcement and they even have that negative interaction, it can really damage them in their probability of being involved in the justice system throughout their life. So it's finding that balance. But this was a great presentation. I appreciate all that information. I just really wanted to kind of get on my soapbox on that step 4 piece, because that's really been a big piece for me post-Oxford shooting. Thank you.
Thank you, and I think you'll find that we're on the same page with respect to the approach to zero tolerance. The threat assessment trainings that are conducted and targeting towards K through 12 schools really impresses upon the fact that zero tolerance is not considered a best practice, that you really want to continue to engage students as much as possible rather than push them out, which can potentially even further their grievance and cause additional problems. So, excellent point that you make there.
Dr. Hans.
Yeah, and thank you, Dr. Posio, for this presentation. And to follow up on John Paul's comment, that is exactly why we need to be involved in this, so that the service or the care or attention that can be provided to youngsters, children, young children or children of any age, including adolescents, can be done in a professional way, which is the least harmful. And that's what exactly was my point when I initially requested this presentation almost a year ago. Thank you.
Pastor Jones and then.
I think this is accolade night as well. Just an excellent report, for us, and I think it brings us up to date on maybe current feelings. A couple of things you mentioned, and I really hope that we can really push that, and that is a lot of the activity is behavioral, not mental, because I think we have a misinterpretation, a perception that all of the things that happen is because of mental illness, and it really isn't. So thank you very much for highlighting that. That's number one. And then the other piece, and I know that in a couple of our solidarity meetings with Christina and a couple of other staff members, we talked a lot about this leakage in relation to who do you talk to? Kids that knew certain things was going to happen, who did they go to? Now, a lot of this, as you mentioned, may be online or, on the web or what have you, but we also found inside of that young kids would either go to a security officer or a teacher that they respected and say something is happening. And I'm just wondering, are you looking at that relationship? Why does that kid choose you to go to say this is going to happen, whether they're upset or whether they know someone else that is? And I know we've been trying to understand that dynamic, but as I look at this and understand it in your steps, that the way they find out about this a lot is because of that leakage, okay, and because it is online. But it'd be interesting to know how do they choose that person. And I noticed that and a number of the school students, as my partner down at the other end of the table is saying, there's a lot of that going on in schools today. Young kids, 4 years old, 5 years old, in preschool, if you will. And then when you get into that 7, 8, 9, and they're just angry about something or just upset about something. And so all of a sudden they call in and say, we're going to shoot up the kid, shoot up the school. So I think it would be great for us to watch that. So the zero tolerance thing needs to be reviewed, because it may just be a moment that kid is upset. Okay, maybe they wasn't selected for the team or something. And so it'd be great to look at that. But great report. Thank you very much. And it's certainly enlightening for us.
Thank you.
Mr. Cowan.
Yeah, Doctor, first of all, thanks not just for the report, but I know your activity in this area and your contribution to the county and to this organization and those you work with. And I know it's a team, so thank you. And this was very enlightening. And I preface what I'm going to ask you is I am not a clinician. I'm just a parent, a grandparent. But and there's no one solution to anything by any means, but just a small thing that I've been catching lately, and I think all of us have. Some communities and school districts and states are looking at taking those, cell phones and devices and putting them away during the school day or the majority of the school day. And I then saw a report today, that, and I don't know what area it was, that, children spending 8 hours a day on these devices. And it just seems to be, one of the things you talked about with the grievance stage, and didn't use the word isolation, but the outside or the isolation. And I think just when you read media reports, especially with kids, that some of them are isolated and they're not interacting with, fellow students. And what do you think about that idea of maybe as part of a overall process or approach with children about the devices and the amount of time they spend all day? Because unfortunately, even though I know there's controls, there's instantaneous access to a lot of bad things.
Mm-hmm.
There's also a lot of good things that they can access. So I'll just throw that question to you.
Well, this might be the subject of a future presentation, perhaps, but I think, you know what, you're absolutely right in saying that there are good and bad aspects of the internet, social media, and that's something that isn't always acknowledged, that both things can be true at once. One of the things that our law enforcement partners, and Tricia can corroborate this, is that anecdotally, our law enforcement partners have noticed that during the period of time when school was mostly remote during the early pandemic, the theory is that kids spent a lot of time isolated and on the internet and getting into a lot of bad stuff on the internet. Okay. And that led to a subsequent increase in threats of violence. And so there's something to that.
Okay.
I think it's an issue that certainly needs to continue to be looked at and studied, but it's something that we are certainly cognizant of.
Well, that's certainly very interesting information. And I might add that just, from my viewpoint, that I think kids today face more pressures and more challenges because of not just the back and forth that they see in their worlds on the devices with their friends and acquaintances and whatnot, but also just from the general public and whatever they access. So that challenge wasn't there when I was a kid, and probably most of us, but it's certainly there today. And I'm just thinking whatever tools, large and small, that can help the process. That's why I brought that issue up. But again, thank you for all the work you're doing.
Thank you. And bullying and harassment, they existed before the internet, but the difference now is that it happens 24/7. It's not relegated to the hours of school.
Exactly. Exactly.
And so the other evidence-based intervention that decreases the risk of violence in schools are anti-bullying programs. And so those are also important programs that need to be supported in concert with things like behavioral threat assessment and management.
Okay, thank you.
Thank you.
Thank you.
That concludes policy management. The 3 reports that we heard tonight will be marked as received and filed. We're down to other business, events and outreach. Susan Warnock. Suzanne. Sorry.
Good evening, everyone. Suzanne Weiner, Director of Communications and Community Outreach. Just wanted to give you my usual rundown of all the events that we have going on this month and next and coming up. The Adoptive Family Initiative, I mentioned it last month, and I'm just absolutely amazed at the generosity of the OCHN family. Our 4th floor cafe was filled with gifts for a few needy families, so we're very grateful for all of their generosity. So just wanted to give you an update on that. Francis already mentioned the Integrated Care Center, the initiative that did a pilot earlier this summer. There was a press conference last week for a highlight of the generous donation from the Penske Family Foundation, a $3 million donation, or pledge, I guess is what they would like to call it, is a pledge, $3 million pledge, to really address the behavioral health needs of the community. So we're really grateful. It was an excellent opportunity to showcase the partnership between all of the different entities, the Oakland County Health Division, OCHN, Honor Community Health, as well as trainings that we have coming up, also the Oakland County Parks Jingle Bell Ball, the adaptive event that we participated in. And then tomorrow I'm very excited to report that we have our Veterans Drive-Through Resource event. It's a partnership with Forgotten Harvest, and the Alliance is also going to be part of it. We expect about 400 people to come through our parking lot tomorrow, so we're really excited. Lots of resources and food that we're going to be providing to everyone. Next slide, please. Also wanted to mention a few events that we have staff attending. Also tomorrow, Dana will be attending the Henry Ford Behavioral Health Hospital Open House, and we have some staff attending the town hall, the virtual town hall on the 11th. And wanted to also mention the OCHN board reception coming up, holiday reception coming up next week. This is our annual event that we'll be hosting in the atrium. It'll be on Tuesday from 5 to 6 before our board meeting, so we hope you all can join us. And as mentioned, there's some other workshops and trainings that are coming up in January. Next slide, please. And some additional things that are coming up in January. We're going to be kicking off the new year with our Law Enforcement Appreciation Breakfast, as we do every year. And it's an opportunity to honor our law enforcement partners and award a few individuals for their outstanding service. So we hope you can join us for that event as well. And then we also are hosting a follow-up transportation forum at the end of the month. So that'll be an opportunity to address some of the questions and just some follow-up with individuals that we serve, as well as some of our provider partners. Next slide, please. Also just wanted to highlight some of the press releases that we have coming up. Actually, obviously one already went out with the press conference. It was a joint press release with our partners for the Integrated Care Center and that generous donation from the Penske Family Foundation. And then we'll be putting a press release out about our Veterans Drive-Thru event tomorrow, as well as just some tips about mental health for the holidays. That's noted our ongoing advertising that we have going on with our billboards, bus ads, television, mall, and radio, as well as we are doing some outreach into the Rochester Hills community with some grant funding, some postcard mailings. Rochester Hills community, obviously because of the shooting that happened over the summer, and trying to reach them and give some promotion to our My Strength application and information for that, as well as hosting our wonderful facility here, and Leadership Oakland will be here tomorrow, so we're looking forward to having them join us in this room. And that's my report. Does anyone have any questions for me?
I do have one question.
Sure.
The training that's tomorrow, approaching persons to help them feel safe and valued, what time is that?
That is a good question.
Is it face-to-face or online?
It would be online.
Okay.
Suzanne, I believe, because that's Sherry's training, most of her trainings are between 9 and 11. If registration is already closed, you can email one of us and we can get you the link to join that.
Okay. Sounds interesting.
We'll make sure you have that information. Thanks, Trish. Appreciate it.
Any other questions?
Is on the vaping piece that's scheduled for January the 9th, what time of day is that, and do we have to register for that as well?
That's in the evenings. It's usually 6:30 to 8 p.m. and it's a virtual only. And usually you do need to register for it, but we can get you that information as well and make sure that if you want to attend.
Again, 8:30 in the evening?
It's 6:30 to 8 p.m.
Thank you.
You're welcome.
Suzanne, can I add, if any of you want to join our email list to receive all of our trainings on a bi-weekly basis, I can sign you up.
I do get the SUD. No further questions. Thank you.
Thank you.
Ms. Barrett.
Oh, board reception. I think Suzanne just covered this, right, for the reception next Tuesday?
Nope, nobody talked about it.
Okay. Sorry. Usually for the December meeting, we have a reception from 5 to 6 that we invite the public for coming for hors d'oeuvres. So if any board members can show up at 5 to 6 for like meet and greets, talk, shake some hands, listen to people. That would be from 5 to 6 in the evening, in the atrium, right, prior to the board meeting. And then, CMHA conference for winter is out. The dates is February, it's in your packet.
3rd.
3rd to the 5th.
Yep.
I know Ms. Newman already confirmed her attendance. And if anybody else wants to confirm, okay. Okay. The rooms are already being booked, so we already secured 4 at least. So if anybody else wants to attend, let us know. Or let me know as soon as possible so we can release a room if we need to. So we got Mr. Collins with us. Yep.
Could I bring up one?
And one other thing, I handed you guys, it's not in your packet, it's at your table. It's the board calendar along with a very, very rough draft of the agenda planning for 2025. I tried to incorporate what is required in there, either through NCQA or CMH or PHP contracts for your guys' review approvals, because those are kind of standing items every year. And then we go forward with the general, there's some, like I didn't remove the committee reports, which I'll remove those. So this is a very rough draft if you guys want to start reviewing that and thinking of some ideas of topics, especially for study sessions, and then and for the policy management or finance committee meetings. And then provide feedback. I'll incorporate and clean up this copy of it, and then we'll go again through the study session over agenda topics for that. And then, Mr. Cowan, I think you wanted to talk about the time.
Yeah, the study session on the 19th, what time is that scheduled to start at?
It starts at 5. You have a executive committee
so it's
meeting
gonna be
from 5 to 6, and then the study session's at 6.
Okay. I was just going to ask if it's possible maybe to move up that meeting to 5 or 5:30. Is that a possibility? Does anybody have complications? I just thought it's pretty close to Christmas, and
yeah.
I mean, we got our jobs to do here, but if we started at 5, maybe we could do the executive session at 4:30.
And we could probably do the executive session in a half hour.
Yeah, that's what I thought.
Yep. So we could do the executive from 5 to 5:30, and then study session start at 5:30.
No. Do the executive session at 4:30.
Oh, and start at 5. Okay.
Okay. Well, why don't we got a board meeting, we have to post it. Is there any objection to that?
I'll just have to change the time on the posting.
Yeah, then let's change it so it's posted properly, 5 o'clock for the start of the meeting, then 4:30 for the executive committee. Yeah.
Will do.
Okay, thank you.
Yep.
Yeah, and then are we going to vote on the schedule at the next meeting?
Nope, you already voted in October.
Okay, I'm sorry.
Yep.
I forgot to vote on it. Okay, no, but okay, fine, that's fine.
Yep. But you can review the dates. We already put them on calendars. Right. They're just not onboardable yet because we still got to do that. But they're already on calendars. Okay. Other than that, I think I'm good. And then this is, again, a very rough draft of the beginning of the agenda planning, just an outline.
Public comment.
Gotcha. Is there anyone online for public comment?
If you are online and wish to speak for public comment, please raise your hand at this time.
Anyone in the room? All righty. We will start with board comments. Dr. Hans? Pastor Jones?
Just want to thank Doctor for just an exciting report today. I thought it was just very, very informative and encouraging, and certainly the work that the staff has done. One more time, just appreciate all the extra effort that the staff puts forward in not only their presentations, but the readiness of what we're doing here at OCHN. Thank you.
Mr. Young?
No, thank you.
Ms. Newman?
Thank you for all of the hard work that goes into the presentations that you give us on a monthly basis. And when we ask you questions, we're not trying to nail you to the wall. We just want to understand. So thank you so much for your hard work.
Dr. Giles?
No comment. Thank you.
Mr. Torres?
No comment.
Dr. Guadalupe?
No comment.
Mr. Cowan?
Yes, just a couple quick things. For the study session, we do have some items with our Chief Compliance Officer that got kind of delayed a little bit, kind of year-end items. Take a look at our bylaws and our governing documents and see if anybody believes there should be any changes. One thing I thought that could be a subset of that is perhaps provide some input to our new CFO if we'd like to see any changes in the formatting of the financial information. I think that would be a good time to do that. And also I added the goals for 2025 and anything that's of importance to the board members on emphasis. So what I'd like to have you do is, would you resend out to everybody the plan we have for 24-25, just so we can have a reminder about that, so everybody can give a little thought to it. Yes, if you could resend that out. And then I'd encourage everybody next Tuesday to try and make it at 5 o'clock, because we do have a number of providers who do show up for our little holiday reception. And finally, I would also ask you to think about, there's a number of items that Suzanne pointed out that are coming up in January, but one that I would ask everyone to think about if they can, because I know it's early in the morning and many have work obligations, but the law enforcement recognition breakfast that we have is really tremendous. And I think any support we can give, whether you can be there or not, the organization is certainly supportive, but I'd ask you to take a look at that one. So that's a very special morning. So thank you.
And I, too, would like to thank all of the presenters tonight for their reports. I know it takes a lot to complete those reports, and you cannot entertain every possible question that you're going to get. So, again, we thank you for your dedication and follow-up. And if nothing further, we stand adjourned.